Hi, my name is Paul Orchard. I'm a pediatrician trained in hematology, oncology, blood and marrow transplantation with a special interest in MPS I. And today we're going to discuss the treatment of MPS I. MPS I, or Mucopolysaccharidosis type I, is a lysosomal storage disease. It's related to mutations within the alpha L iduronidase gene, or IDUA gene, and defects in that gene lead to accumulation of substrate, including a number of glycosaminic glycans, including dermatan sulfate and heparan sulfate.
There's essentially two subtypes in terms of clinical aspects. The first is Hurler syndrome, which is a more severe form and more common form. The attenuated disorders have also been referred to as Shea or Hurler-Shea syndrome. Severe MPS I or Hurler is about 1 in 100,000 births, and attenuated MPS is more in the 1 to 500,000 frequency. It's important to understand that there are multiple organ systems that can be affected by this disease. A key one is the neurologic aspects or developmental delay. This is primarily an issue in Hurler syndrome, or the severe form. These patients cognitively lose ground early in life. They can also develop issues with hydrocephalus. Airways and pulmonary aspects of the disease can be significant as well. Patients accumulate storage material in the soft tissues of the airway. They can be difficult to intubate. They can have obstructive apnea. The families commonly give a history of snoring and difficulty sleeping. The majority of these patients, especially the severe patients, will have changes on echo very early in life. Valvular changes such as thickening of the mitral valve are very common. And some of these patients also can have significant decreased cardiac function. Organomegaly is prominent, especially hepatomegaly. And the patients can be noted at birth to have umbilical or inguinal hernias, and sometimes they become apparent later. Corneal clouding is a significant issue, and to a lesser degree, some of these patients have retinal degeneration as well, although that's not as well defined as we would like yet. Hearing can be a significant issue. They accumulate fluid within the ear and have conductive hearing losses, but also can have sensory neural hearing losses. And many of these patients require hearing aids later in life. The important aspect of the disease is the effects on the skeletal system. So dysostosis multiplex is the terminology used for the many changes that we see throughout the skeletal system. Both bone and cartilage, as well as tendons, can be affected. Restriction in the range of motion can be apparent. Patients tend to have limited growth despite therapy with enzyme or with bone marrow transplantation. In terms of the back, kyphosis can be apparent very early in life and sometimes even at birth. Hips can be affected, both the acetabulum and the proximal femur. Patients can develop valgus deformities of the knees, as pictured here. On x-rays, vertebral bodies can be shown to be hypoplastic and tend to have anterior beaking. Cervical instability is less common, but can be an issue and can be a significant concern in regards to intubation of these patients for procedures. Also less common is spinal cord compression through the accumulation of glycosaminic glycans along the spinal cord, and this can require surgical decompression as well. Carpal tunnel is a common finding also with these patients. Regarding therapy for MPS I, allogeneic transplantation was first explored by Hobbs Group and reported in 1981. A patient with MPS I was transplanted with cells from his mother and showed both biochemical improvement as well as improvement in the soft tissues of the patient. This really set the table for use of transplantation since that time, and hundreds of patients have been treated with MPS I thus far. The rationale here is that cells that are producing enzyme that are derived from a normal donor can circulate throughout the body and provide lifelong source of enzyme for the cells that are deficient. The cells have the capacity to recognize enzyme, internalize it, and take it into the lysosome where it can be utilized in breaking down the glycosaminoglycans. Enzyme replacement therapy has also become available. The gene has been cloned. It can be utilized to make pharmaceutical product that it can be provided to the patients intravenously and generally is given every week. The enzyme circulates through the body and can be incorporated by the cells that are deficient, internalized into the lysosome, and be used to break down the storage material. The half-life of the infused enzyme is quite short, and so needs to be administered on a weekly basis. Enzyme has also been used in association with transplant, primarily prior to transplant, as transplant donors are being established and the procedure is being set up. In terms of treatments that are under investigation, the use of intrathecal enzyme has been explored in an attempt to decrease the cognitive dysfunction that's apparent in the disease. It was a limited trial, and it's important to understand that intrathecal enzyme is not approved for this disorder. There is interest in developing new proteins, new enzyme that may have the ability to better localize tissues in the body, such as the brain. This has not yet been explored in a clinical trial, but has the capability of being developed. And there's a great deal of interest in gene therapies also in treatment of MPS I. In terms of choice of treatment options, there is variation based on the phenotype. The patients that are relatively early in age would be expected to have a severe phenotype or Hurler syndrome. These patients would be expected to lose cognitive function and would go on a pathway that would include transplant, although they may get enzyme therapy prior to transplantation. The patients that are older at diagnosis would be expected to have either more attenuated disease or would have severe disease that would be quite advanced. And in that situation, the recommendation would be to go just on enzyme and not necessarily pursue transplantation. Related to outcomes with transplant, the point of this slide is that over time, the transplant outcomes have improved. This is data from 258 patients in a multi-institutional trial. But as you can see, the survival of patients has improved over time. At this point, in the groups that are transplanting a fair number of patients and have experience with the disease, the overall survival is 85% or above. It's important to understand that age of transplant is important. So in that same study, the median age of transplant was 16.7 months. And if the patients are divided based on age, the overall survival is much better in the patients that are younger at the time of transplant. Related to cognition, patients diagnosed with a severe form of the disease lose neurocognitive function over time. Early in life, their cognition appears to be normal, but over a period of several years, there is marked decrease in cognitive function. So this is a goal of treatment, and this is data from that same trial looking at cognitive outcomes. So several important pieces here. If we define a normal IQ as above 85, prior to transplant, 56.9% of the patients were in that group. But following transplant, a year or two after transplant, while cognition can be stabilized, a significant amount of ground has been lost, and 26.9% of the patients were considered in the normal IQ range. In terms of severely affected patients, only 16.5% were severe prior to transplant, but fully 45% of them were severely affected after transplant. So this is an unmet need in terms of being able to stabilize cognitive function. Factors that are important in this: the boys did not do as well as the girls did. If you came into transplant with a low baseline IQ, that was significant. If you were older at the time of transplant, that again was very important. We used to use total body radiation as part of our preparative regimen for transplantation. That's not something we do anymore, but the patients that received total body radiation also did not do as well. Another important aspect of the disease following transplantation is the effect on the skeletal system. This slide depicts growth-related issues following transplant. While a majority of the patients were within the normal growth curve prior to transplant, over time they tend to fall off the growth curve, and fully 70+% of these patients by 7 years are not on the growth curve anymore. So transplantation is insufficient to cure the skeleton sufficient for normal growth. Also important are the skeletal complications related to the disease that these patients experience despite transplantation. So the requirement for surgical procedures, even in the patients that have been previously treated with transplant, are depicted here. Carpal tunnel syndrome is a common one. Kyphosis and potentially scoliosis as well can be apparent and may need intervention. Knee and hip issues are also commonly observed and requiring procedures. Cord compression less so, but this is an important aspect as well. In terms of enzyme replacement therapy, the initial studies that were used to establish or obtain a license for the enzyme included looking at pulmonary function and 6-minute walk tests. Biochemically, the glycosaminoglycans were decreased and organomegaly was improved. Enzyme was reasonably well tolerated, and those aspects were quite clear. In terms of difficulties associated with enzyme replacement therapy, it's not as effective as we would like it to be. Most of the benefits that are obtained are in the soft tissues, as opposed to skeletal disease or cardiac disease or other issues. Because of the short half-life of the disease, patients need to receive infusions essentially weekly throughout the rest of their life. And the agent is expensive. The cost per patient depends on the size of the patient, as one might expect, but it's several $100,000 a year for as long as the patient is on therapy. The slide depicts the various outcomes related to therapy for MPS I, for the severe form of MPS I. Untreated, most of these patients die in the first decade of life, primarily from cardiopulmonary related issues. As enzyme became available in 2004, there was a number of families that decided to treat their children with enzyme alone and not proceed with transplant. Survival curves here for that population are depicted, and also how the patients have done with transplantation. So you can see enzyme certainly extends survival, but at least in this analysis was inferior to transplantation. Also in this analysis, it demonstrated the difference between the patients that developed hydrocephalus in those that were on enzyme and those that were transplanted. Transplant, because donor-derived cells can make their way into the brain and potentially serve as a source of enzyme. This is thought to be the reason that the patients that have undergone transplant are much less likely to have hydrocephalus following therapy. So in summary, MPS I is a rare lysosomal storage disorder. It is multifactorial and affects most of the organ systems of the body. The treatment has been dependent on the phenotype, so the severity of the disease. The patients that have severe disease, the MPS I-H population or HERMA population, be expected to have cognitive decline. And because transplant may better affect the central nervous system than enzyme, patients with severe disease generally go to on a transplant pathway. For those patients that have attenuated disease or for whatever reason cannot be transplanted, they go on enzyme, which generally is administered weekly throughout the life of the patient. It's also important to understand that neither therapy is curative, and many of these patients go on to have significant disease-related morbidity despite being treated with transplantation or with enzyme therapy. We're going to have the opportunity now to identify patients essentially at birth with newborn screening, which will be a huge opportunity. It's much easier to help prevent disease-related complications than to improve them once they've occurred. So the opportunity to establish the disease in these patients very early and intervene early is going to make a huge difference in the anticipated outcomes of these patients.